The topic of discussion is diagnostic and therapeutic challenges in uveitis, a simplified approach. Uveitis is not a specific disease, rather it's a general term to categorize a group of inflammatory processes. Now, based on the various case series, the annual incidence of uveitis is 17 to 52 per lakh population. Among them, over half of these people developed some amount of complication related to this condition. Up to 1/3 suffer visual impairment, and it can cause 1/4 of total blindness in developing countries. So we'll be discussing the various classification used in uveitis. First is the Woods classification, which differentiates into the granulomatous and the non-granulomatous entity, though it's often known as pathological classification. This actually helps us to narrow down the differential diagnosis based on the clinical feature. Next, we have the Duke-Elder classification, which classifies according to the etiology, the cause of the uveitis. Then we had in 1987, we had the AIOC classification, where the uveitic entities were classified according to the anatomical site of the inflammation. Then in 2004, we had this most sophisticated classification of uveitis, known as standardization of uveitis nomenclature, also popularly known as Sun classification. Now, Sun classification deals with the primary site of inflammation. If the primary site of inflammation is in anterior chamber, then we call it anterior uveitis. If the inflammation is in the vitreous, then we label it as an intermediate uveitis anatomically. If the primary site of the inflammation is retina or choroid, we call it posterior uveitis, which is again classified into various subgroups. Now, if there is no predominant primary site of classification, but the inflammation is observed in anterior chamber, vitreous, or retina or choroid, then we label it as Panuveitis. So, while evaluating a case of anterior uveitis in the exam, first you have to take a brief uvea related history to differentiate the particular case into what is the onset of the uveitis, what is the duration, and what is the course. These parameters were addressed in Sun classification. These are known as descriptors of uveitis. So if you see, the onset is divided into sudden and insidious. Duration is based on 3-month time period, which is limited and persistent if more than 3 months duration. The course is again divided into acute, chronic, and recurrent. Acute is characterized by the sudden onset with limited duration. Can you switch off this slide? Duration. And it can be recurrent also, repeated episodes, where after the discontinuation of the treatment, if it's less than 3 months of duration. More than 3 months duration, then we call it recurrent. If it's a chronic uveitis, if after discontinuation of the treatment, the persistent uveitis is seen even after less than 3 months of treatment. Now, next important is the congestion. We are not going to discuss the differentiating between the episcleral classification and conjunctival classification, but sometimes uveitis can present even without congestion also. So those are termed as vitae uveitis. It's a very important question in the exam, both theory and for practical purpose also. The causes of the uveitis are pars planitis, Fuchs' heterochromic cyclitis, juvenile rheumatoid arthritis, etc. The next parameter is grading the inflammation. So grading the inflammation can be done with a slit-lamp beam of field size 1 millimeter into 1 millimeter, where we count the number of the cells and grade this inflammation from 0 to +4. The trace grading is marked as 0.5. Can you switch off the slide? So similarly, the flare, the aqueous content, fibrin content of the aqueous humor can be graded according to the visibility of the iris and lens detail, and it can be graded according to +1, +2, +3, +4. +4 is the intense fibrin, where the plastic fibrin is observed in aqueous anterior chamber. So next parameter is the keratic precipitates. Keratic precipitates is very important. In exam, you should document the extent of the involvement of the keratic precipitate, whether it's diffusely involving the corneal endothelium or it's forming a line called Turk line. Sometimes it's very important to note down the size of the capes also. For example, the fine small capes are commonly associated with non-granulomatous anterior uveitis. The large mutton fat keratic precipitates are most commonly seen in granulomatous anterior uveitis. It can be seen in Fuchs uveitis also. Stellate capes are characteristic of the Fuchs uveitis, and chronic uveitis is characterized by the pigmented keratic precipitates with crenated margin. The next one should carefully examine the iris details. There are mainly two types of inflammatory nodule. One is the Koppes nodule, which is situated into the pupillary border, and the Boussaka's nodules are seen in the collarete. Now here is just a trivia. The Koppes nodules is named after Leonard de Koppe, a German ophthalmologist. He is also known for popularizing and making improvement in the slit-lamp. Now my question is, can you name any other ophthalmic aponym associated with him? Very good. This is the Koppes lens. So the next is to differentiate between neovascular iris vessels and the normal iris vessel. So neovascular iris vessels start as a bud. It most commonly arises from the pupillary margin, whereas the normal iris vessel radially arranged within the stroma, and on gonioscopy it does not cross the scleral spur. Then iridolenticulaire synegia can be divided into broad-based synegia, festooned pupil, occlusio pupil, and the seclusio pupil. Now, what is the type of this synegia? Only the central part is attached. Anyone? This is a googly actually. This is persistent pupillary membrane. So don't confuse persistent pupillary membrane with synegia. So next important feature is the iris atrophy, which can be seen in various viral diseases. The sectoral iris atrophy, most characteristic of varicella zoster virus, and diffuse iris atrophy can be seen. So iris heterochromia is another important feature of Fuchs heterochromic uveitis. But one should remember that in a Indian population where the iris is heavily pigmented, often the heterochromia is very subtle. So one should look carefully for the fine patterns of the iris. In Fuchs, the fine pattern of the iris is lost. Next important, one should, for exam purpose, know the causes of hypopyon and hyphema. While in viva or practical examination, just start with the most common causes and then go for the rare causes like malignancy or Masquerade syndrome. Hyphema. Another important is lens. You should look for the complicated cataract, whether there is any polychromatic luster, which indicates the chronic uveitis. Beware before initiating any treatment to rule out the chronic endophthalmitis. Then IOP is very important. There are various inflammatory conditions where intraocular pressure is raised. Then comes the gonioscopy. Gonioscopy is very important. It gives us helps us to diagnose the peripheral anterior synegia. Sometimes the hyphema and very importantly microhypopyon can be actually examined with the help of this gonioscopy. So gonioscopy is very important in a patient where you are suspecting Behçet disease. This typical entity called microhypopyon is a characteristic of the Behçet disease. Then you can see the exudates also. Now my next question, what is Barlin nodule? Yes? Barlin nodules are the iris nodules seen in the anterior chamber, which can be found out with the help of gonioscopy. So these are most commonly seen in sarcoidosis. So next important is the examination of the vitreous cell. Vitreous cell is a very important signs of intraocular inflammation. One should carefully examine the retrolental part. So if you see string of pearl appearance in retroillumination and the vitreitis, which is a very important feature of the pars planitis or intermediate uveitis. So this vitreous haze, if you have seen a vitreous haze, then you have to classify this. Unfortunately, this Sun classification, they don't have separate grading for the vitreous haze. So what they have done, they have adopted the National Eye Institute system for the vitreous haze grading in their classification, which classifies from 0 to 5 based on the posterior pole details. Now, while evaluating a case of intermediate uveitis, it's very important to know the difference between the snowball and snowbanking. Snowballs are the round yellowish exudate which lies in close proximity to the retina but does not never in contact with the retina. Whereas the snowbanking is the exudates deposited over the pars plana, and snowbanking represents more severe form of the intermediate uveitis. These are the clinical picture of snowball and snowbank. So now the common causes of uveitis in exam, you should enumerate these causes as infectious cause and non-infectious cause. So it starts from the tuberculosis, which is most common in India. Then it can be because of the multiple sclerosis, sarcoidosis, intraocular lymphoma, etc. Now, Sun classification has given clear guideline when to call this anatomical intermediate uveitis as pars planitis. In absence of any associated infection or systemic disease, we'll call it pars planitis, and if there is associated infection on some systemic disease, then we call it intermediate uveitis. So next, this cystoid macular edema, which is most common complication and cause of diminution of vision of intermediate uveitis. This is very important, that CME can be the complication of any type of uveitis, starting from the anterior uveitis, post panuveitis. So, it's very important that the presence of CME and CNVM should not lead to the naming this inflammation as posterior uveitis, if the cause of the foveal pathology is not related to retinal or choroidal inflammation. Okay? So now, if you are evaluating a case of posterior uveitis, there should be first the two question is very important, whether it's a case of posterior uveitis alone or it's a part of panuveitis. So you have to rule out the other primary sources of inflammation, whether the inflammation is present in vitreous, in the anterior chamber. If it is a case of posterior uveitis alone, then you have to differentiate whether it's retinitis is there or choroiditis is there. So retinitis and choroiditis can be differentiated. This is the edited image. So choroiditis generally present as a white patch. The borders are fairly demarcated, and the retinal vessels, if you see in the choroiditis cases, can be seen normally. Whereas in case of retinitis, the retinal vessels are obscured. The outline is somewhat indistinct and generally whitish in color. Now, there may be combination of the retinitis and choroiditis, which is known as the retinochoroiditis. The typical example is the toxoplasma retinochoroiditis. So, once you are sure that it's a case of retinitis and choroiditis, then next important step is to whether it's a case of focal or multifocal or diffuse. Now, there are various causes of this focal retinitis, and multifocal retinitis are commonly seen in viral diseases like HSB, VZB, CMV. And similarly, the focal choroiditis, can be seen in toxoplasmosis. Serpiginous choroiditis can present as both focal and multifocal also. So once this evaluation is complete, then next important is to see whether there is optic nerve head involvement or not. If the optic nerve head involvements are there, then think about sarcoidosis, toxoplasmosis, VKH, syphilis. Remember, this can present as panuveitis also. So next important, look carefully the periphery of the fundus, whether there is a choroidal granuloma, tubercle or subretinal abscess. If you see here it's a case of choroidal tubercle. You can see the vessels are clearly, you can make out these vessels. This is a case, and some subretinal fluid here, and here is a subretinal abscess. So the term, this panuveitis, as I told, there is no predominant site of inflammation, but there will be lot of the inflammation observed in the anterior chamber, posterior chamber, and retina vitreous. So if you see a case of panuveitis, it can present broadly as three types. First is it can present as predominant vasculitis. There will be vitreous, anterior chamber reaction, but the predominant feature will be vasculitis. So in that case, think about most common three causes: Behçet disease, tuberculosis, sarcoidosis. Now, this vasculitis cases can be again differentiated into the involvement of the vessels. Primary arteritis are seen in mainly the collagen vascular diseases like Ancillary, PAN, then sometimes in viral diseases like acute retinal necrosis. Veins are involved in cases, most common example, sarcoidosis. Sometimes both the vessels can be involved in Behçet disease, multiple sclerosis. So, in case of panuveitis with a hypopia with predominant vasculitis, one should suspect Behçet disease also. So, suspect Behçet disease if you have the following features also, like oral ulcer, genital ulcer, pustular skin lesion, and vasculitis. Remember, the same kind of skin lesion, the pustular skin lesion, can be seen in patient with prolonged oral steroid therapy also. So you should know, for the theory purpose, the international study group for the Behçet disease classification, where the classification, they have clearly defined the diagnostic criteria that recurrent oral ulceration and present of these two other criteria like genital ulcer, eye lesions, skin lesions, and positive pathology test has to be there to diagnose a case of Behçet disease. So next variety of the panuveitis. The first was the vasculitis. The next is the predominant retinitis and choroiditis. In such cases, think about tuberculosis, viral, acute retinal necrosis, and Behçet disease. One should suspect acute retinal necrosis if you are examining the patient with a vitreous haze and you see on the periphery there is a discrete areas of peripheral retinitis or some confluent areas of peripheral retinitis. So one should suspect acute retinal necrosis in such cases. The last variety, the predominant panuveitis can present with predominant exudative retinal detachment. Then think about two conditions. One is leakage, another is sympathetic ophthalmitis. Look for, if one patient has come with panuveitis with bilateral exudative retinal detachment, look for white patches, the patchy hair loss. This can be a case of Vogt-Koenig-Harada's disease. Also, take the history, ask for headache, any history of headache, meningismus, vertigo, or any history of hallucination, auditory hallucination, or tinnitus is there. Then, for the theory purpose, you should also remember this revised diagnostic criteria. This is a very long criteria. I am not going into the details, where this classification helps us to differentiate the leakage as complete, incomplete, and probable. One of the important recommendation by this criteria was, which we are doing in our everyday practice, that the term Harada's disease should not be used. So now we should not use the term Harada's disease. Instead, this classification has helped us to classify the leakage in complete, incomplete, and probable. So in India, we are seeing most commonly this probable group of leakage. So suspect one panuveitis case has come to your outpatient department. You should suspect Behçet disease if there is granulomatous inflammation in the anterior chamber and there is subretinal fluid or exudative detachment. The same kind of picture, unilateral with other eye, history of penetrating injury, one should suspect sympathetic ophthalmia. So now, while we have a lot of this ancillary test in uveitis, starting from fundus color photography to the recent fundus autofluorescence. So fundus fluorescent angiography can be used for the diagnosis. This is a very long list, but the rule is, whenever you see a posterior uveitis, except the toxoplasma retinoitis, always do a fundus fluorescent angiography, which helps us to determine the exact extent of the lesion and follow the disease process also. For example, in Behçet disease, the golden standard of investigation is the fundus fluorescent angiography, which helps us to determine the progression of the vasculitis. So fundus fluorescent angiography in vasculitis in active vasculitis cases shows narrowing of the vessels. It can show leakage of the and staining of the dye from the vessels. It also helps us to diagnose the neovascularization, which can be seen as multiple foci of the fuzzy hyperfluorescent patches. And in Ehlers disease, it helps us to, because in Ehlers disease, the neovascularization are commonly seen in between the junction of the perfused and the not perfused retina. Similarly, in choroiditis also it helps us. You have to just look carefully the border of the lesions. The borders, the margins of these lesions are fuzzy in cases of active choroiditis, whereas the margins are well defined in cases of the healed lesion. Similarly, the CNVM in uveitis usually occur at the edges of the heel scar. So, fundus fluorescent angiography helps us to diagnose this with this early lacy pattern of hypofluorescence. Similarly, this fundus fluorescent in Vogt-Koenigsegg disease, which typically shows pinhead leak at the early phase, which gradually increases and shows the plaquette pulling in late frames. So, this is not very specific, because the similar condition can be seen in the sympathetic ophthalmitis, some other condition also. For example, see, this is a 23-year-old patient came to my OPD with sudden diminution of vision in left eye. The base corrected visual acuity was 6/12 and N10 or 12. What is your diagnosis? Anybody? See, we did one angiography and it showed us this small leakage which was increasing in the intensity and sizes in the later frame. So it was a case of multiple leak CSR. So one should be very careful before starting any treatment, because the management of these two conditions are paradoxical. So it's very important to do a fundus fluorescent angiography. The fundus fluorescent angiography also helps us in CME, which shows progressive leakage and accumulation of the dye and shows the classical patellard appearance. While evaluating case of this cystoid macular edema, OCT is always preferred. I'll tell you the reason. See, this is a case without treatment and this after treatment. See the extent of the this dye accumulation. The spread of the dye is almost same, but see the OCT. So the OCT helps us to measure the macular thickness properly. So it's very helpful. It's also, AOCT is also helpful in epiretinal membrane and choroidal neovascular membrane. The ultrasound B-scan uveitis can be very important, especially in cases of posterior scleritis, where it shows the diffuse thickening of the posterior coat. Also in cysticercosis, where in kinetic ultrasonography you can see the spontaneous movement of the scolex of the cyst. Classical example where we will advise ultra biomicroscopy is if the patient has come with occlusio pupillae and you are suspecting pars planitis, a condition the patient has present with chronic hypotony. Then in that case you have to do ultrasonography, which helps us to see the ciliary body status, the pars plani inflammation, whether any exudates are there or not. Sometimes IOL related uveitis also, it helps us to see whether any haptics are rubbing the ciliary body and causing the inflammation or not. So this is the basic of this newer investigation called autofluorescence. For this I'll just take a minute. See what happened normally, there is each RP cell normally is phagocytes by the photoreceptor, the outer segment disc. So what happened, these discs are engulfed in the RPE cells, and these are known as phagosomes. Now these phagosomes are degraded intracellularly by the action of the lysozyme. What happened after that? The teeny fraction of accumulatory products are incapable of chemical digestion and accumulates as lipofuscin. So as all of us know that the lipofuscin is the classical wire and tear pigments, at the age of 70 or in disease processes almost fills the entire RP cells. So this signal is very important. So the study of the lipopustine content of the RP cell can be give some insight to the pathogenesis or the progression of some diseases. The fundus autofluorescence signal is increased if with the RP dysfunction. It's decreased if there is RP loss or photoreceptor loss. Okay, we'll see. See, here is a case of choroiditis in various stages of resolution. You can see the active border here, and here is the healed part. You see here, it's showing, it's giving us the increased signal of the autofluorescence, whereas the healed part, it's showing the decreased signal. So this is very important because it's a non-invasive test, so we can follow the patient over a period of time. Now, there are a lot of laboratory workups are there. So don't go for this fishing expedition. Before just planning the laboratory workup, just there is a stepwise approach. First, take one uveitis oriented history. Then just go for the comprehensive eye examination. Then identify the anatomical location, and then decide about the primary site of the inflammation. Just brief systemic examination, which will help you to decide about the laboratory test. We'll see one example. One 40 years male with severe pain, redness of the right eye. Slit-lamp examination showed anterior uveitis with hypopyon. No history of intraocular surgery. What laboratory test you will do? See, there can be three situations. One is the patient has fibrinous non-mobile hypopyon. We'll just evaluate further. After examination, the inflammation is limited to anterior chamber only. The patient give you the history of recurrent inflammation, and he also give you the history of low back pain, stiffness in the morning. So what investigation you will do? We'll rule out ankylosing spondylitis. We'll do simply, we'll advise X-ray L-spine and HLA B27. The same, the patient with mobile hypopyon, the anatomical inflammation is there in both three chamber, three part of this thing, uveal tract. So then the patient is giving you the history of recurrent oral ulcer, and the patient on systemic examination you can see some skin rashes or genital ulceration. So what investigation you will do? You will rule out Behçet disease. The third case, similarly one patient has presented with hypopyon. There is panuveitis, and the patient has given you the history of intravenous medication or prolonged hospitalization, and on examination you can see a large boil, some abscess somewhere in the body. So what investigation you will do? You will send the patient for vitreous biopsy to rule out the endogenous endophthalmitis. So it's very important. Similarly, one female, 28 female has come to your OPD with mild diminution of vision. It's a case of non-granulomatous uveitis, no history of prior attack, of severe inflammation. What test you will do? There are some conditions where we don't order any test, like Fuchs heterochromic iridocyclitis, traumatic uveitis, first attack of the non-granulomatous uveitis, and unequivocal cases of leakage or sympathetic ophthalmia. No need of investigating these patients. Sometimes the diagnoses are always clinical. For example, the toxoplasma. Though the sensitivity is 100%, the specificity of the test is only 50%. So always try to correlate these conditions. This is one of my favorite questions. This is a patient, 45-year-old lady, has presented with past history of bilateral facial palsy for 8 years. She is complaining of floaters for 4 months, and she is on topical steroid and cycloplegic. The slit-lamp examination showed the presence of iris nodule and the mutton fat capes. And the fundus examination showed the pars plana exudate. So what laboratory test you will advise? So from this history, if you see, I have underlined those. There is a history of bilateral palsy for 8 years. There is a patient is complaining of floaters, and there is a blurred vision. And the duration of this uveitis is 4 months. So it's a case of granulomatous uveitis. And the site of the inflammation is primarily in the anterior chamber and vitreous. On systemic examination, you have found that there is a mild tender erythematous plaques typically involving the shins of our tibia. These are erythema nodosum. So she, on her detailed history, she gave you the history of chronic cough, mild tightness in the chest. Now, if we summarize this case, if you see the chronic granulomatous uveitis and anatomical location of this anatomically intermediate uveitis, the most common causes in India, TB and sarcoidosis. History of chronic cough can be there in TB and sarcoidosis also. The tightness of the chest goes more in favor of the sarcoidosis. Now, history of facial palsy. It's an important sign of the sarcoidosis. If associated with parotitis, we call it Hereford syndrome. There is erythema nodosum. Though it's a non-specific finding, it can be seen in sarcoidosis, and it's, if associated with bihilar lymphadenopathy, we call it Lofgren syndrome. So now what test you will advise? We'll straight away go for the ceramycin and lysozyme, which will give an idea about the macrophage number load. Liver enzymes. Why liver enzymes? Because liver is one of the occult site of the sarcoid nodule involvement. Also, sometimes this kind of patient with recurrent inflammation may require immunosuppressive in later phase. So it's better to do a liver enzyme. We'll do chest X-ray, though nowadays the HRCTs are preferred. So I will also like to do tuberculin skin test. Why? Because first, India is an endemic country for the tuberculosis. One must rule out the tuberculin skin test before starting any oral steroid or immunosuppressive. And if you see international criteria for the diagnosis of the ocular sarcoidosis, the first criteria for the laboratory, which includes 5 parameters, clearly says the negative tuberculin test in a previously BCG vaccinated person is an important parameter for the diagnosis of oral steroid. For theory purpose, you must read this article, the international criteria for the diagnosis of ocular sarcoidosis, which was published in 2006. Now, how well is the Monto test in India? It's positive in 30 to 69%, but in our institution, what we still value high Monto, more than 20 millimeter. This is very important for the theory purpose. You have to know what is interferon gamma release assay, where is the heparinized blood vessels are taken, and this exposed with the specific tuberculosis antigen, and the production of interferon gamma is measured by the ELISA. Only problem with this interferon gamma release is it can't differentiate between active TB inflammation and the latent infection. Now it's a case. What is the diagnosis? Anybody? Acute. Very good. Acute retinal necrosis. Now, what investigation will do in this case? Rather, why it's important to investigate a case of acute retinal necrosis? Straight away you will start antiviral. But if you see, the acute retinal necrosis is caused by the herpes simplex virus 1-2, varicella zoster, and the cytomegalovirus. So this group of virus will respond to acyclovir. Whereas the CMV, what will happen? Because the thymidine kinase is not there, so it will not respond to acyclovir. You have to inject ganciclovir. So here comes the importance of the causative organism. So a simple aqueous aspirate can help us to diagnose and treat this patient. Now this PCR, any sample can be sent for polymerase chain reaction, starting from the conjunctival swab, tear drop, aqueous aspirate, vitreous biopsy, coronatal biopsy can be sent for the polymerase chain reaction. Now, the newest technique is the real-time PCR. What is this technique? The real-time PCR is a technique used to monitor the progress of a PCR reaction. So, one fluorescent molecule is used which measures it manifolds as the PCR products accumulates in each cycle of the amplification. Advantages are it quantifies the organism. It's very simple. It's relatively quick. The result can be obtained within the 12 to 24 hours. And there is an improved sensitivity and specificity. Now, how it's useful? We'll show. I use the term quantification of the microorganism. See, this is a patient who presented with this atypical retinitis. he gave us the history of some kind of viral fever following he had developed this kind of diminution of vision and this. So we took this aqueous aspirate and sent for real-time polymerase chain reaction. The real-time polymerase chain reaction not only diagnosed the virus, this technique quantified the 9 copies of viral mRNA is present in the per ml of the aqueous sample. So this is the utility of the real time. It quantifies the viral load in the aqueous humor also. So this was a case of checking on a retinitis. Now what's going on here? It's a leech is used in the treatment of the uveitis. So if you go to the history of the uveitis, the treatment of the hypopian uveitis was described by Scarpa in 1805, where he treated this patient with bleeding her abundantly by applying the leeches over the both angles of her eyes. Luckily, we don't have to depend on these leeches. We have various agents like NSAID, corticosteroid, immunosuppressives, and biologicals. So aim of any treatment is uveitis treatment is relief of the symptoms, preservation of the vision, and prevention of the complication. The factors which modifies is anatomical location of the inflammation, bilateral or unilateral laterality of the inflammation, whether the inflammation is chronic or recurrent, or what is the degree of inflammation. We'll see with the help of one example. This patient has presented to you with anterior uveitis. Unilateral involvement. What will be your treatment? You will start topical steroid. If the inflammation is severe, you will use topical steroid frequently. If it is less, then you will use it 4 to 6 times a day. Correct? So now the same picture, same kind of slit-lamp picture, but there is vitreitis and the pars plana exudate. The anatomical location is changing, unilateral involvement. You will treat with topical and periocular steroid. Same pattern, only the bilateral involvement. What will be your treatment of choice? Oral steroid. Correct? Now, the same pattern, only there is history of bilateral recurrent attack. Every time you are stopping the steroid, the patient is coming with rebound inflammation. So what will be your treatment strategy? You will use immunosuppressive after ruling out infectious etiology. So this is how it changes. Now we have various routes of corticosteroid like topical steroid. Eye ointments are though very rarely used. Periocular like subconjunctival, subtenon, systemic oral intravenous, and the intraocular treatments. So now the topical steroid. Lot of preparations are available in the market. Prednisolone acetate, dexamethasone phosphate, betamethasone sodium phosphate. Which one is the better? We'll see here. This is actually fight between the solution and the suspension and acetate and versus phosphate. How? Solution like betamethasone drop. They have poor penetration, cause less discomfort, and requires less patient compliance. Any patient you can give, without any patient compliance it can be used. But in cases of suspension like prednisolone acetate, what happens? It actually normally it remains like this. Then after shaking it achieves the desired concentration. So they give us the better penetration, cause more discomfort because the particulate nature of the drug, and require more patient compliance. In a study it has been seen it has to be shaken 20 times to achieve the desired concentration of the suspension topical steroid. So given this patient compliance, the suspensions are the preparation of choice for the topical steroid. Now we'll see this acetate and the phosphate. What is the difference between these two? Phosphate has only hydrophilic moieties, whereas the acetate, it has both lipophilic and hydrophilic moieties. And if you see the drug, this barrier, anatomical barrier, corneal epithelium is lipophilic and the stroma is hydrophilic. So who wins? Acetate is the winner. So that is the reason prednisolone acetate, though it's 6 times less potent than the dexamethasone on molar basis, still it's the preparation of choice in anterior uveitis. Next is cycloplegic. All of you know what is the mechanism of the cycloplegic, how they act. I'll just go into what are the available the cycloplegics. Atropine, homatropine, most commonly used in the uveitic management. There is another cycloplegic called cyclopentolate also. Some people use cyclopentolate also for the treatment of the uveitis. But a group of the worker, they found that this is chemoattractant to the inflammatory cells. So it's not recommended for the uveitis treatment. And once again, the phenylephrine is not cycloplegic and it causes pigment release in anterior chamber. So sometimes after dilatation also with phenylephrine, some patient you'll have some pigments floating in the anterior chamber and you can mistake it as a case of uveitis. So phenylephrines are not used in the treatment of the uveitis. Now the Sun classification has some parameters like what is the improved activity and what is the worsening activity, like 2-step increase and the 2-step decrease. All these are there. So the treatment of the intermediate uveitis is actually step-ladder pattern protocol. So don't confuse with the Kaplan approach and the modified Kaplan approach. The modified Kaplan approach is the treatment strategy which we are using. Like periocular, first we treat with periocular steroid, then move to oral steroid, then immunosuppressive and laser and cryotherapy. So local application, what happens here? The highest possible amount of the drug is delivered to the eye and the least amount to the rest of the body in case of local steroid. Whereas in cases of systemic steroid, what happens? It delivers more drug to the rest of the body and relatively very less amount to the eye. So we have intravenous methylprednisolone, which is very effective in treating the visually threatening uveitis cases, but it has a significant side effect like cardiac arrhythmia or cardiovascular collapse. There are a lot of side effects of the systemic steroid. And local steroids are most commonly known to cause two significant side effects like cataract and the rise of intraocular pressure. Now, intravitreal treatment, it's very important. It's becoming very popular nowadays. So if you see, we have corticosteroid. A lot of corticosteroids are used. We'll discuss in the next slide. The anti-VEGF, bevacizumab and ranibizumab has been used successfully for the treatment of the CNVM, inflammatory CNVM and cystoid macular edema in some cases. Immunosuppressive, this methotrexate has been tried, and this present sirolimus trial is going on in various centers. And etanercept, some anti-TNF alpha has been tried as intravitreal treatment. Now, if you see the pharmacological property of this corticosteroid, here you see the triamcinolone acetonide. The half-life is 18 days, but it has a relative potency 1. If you see here, the dexamethasone, though the half-life is 3 to 5 hours, it has 3 to 5 times more potency than the triamcinolone acetonide. So, what we have done, we have tried to devise some intravitreal corticosteroid implant. First, we tried with, which was first FDA-approved device, Retisert, which contains the fluosinolate acetonide, and it releases 0.59 mg of the fluosinolate acetonide in the vitreous cavity for 30 months. So the other group, we modified that because the dexamethasone has higher potency than this triamcinolone acetonide and the fluosinolate acetonide. So we devised another device called Azurdex. So what Azurdex, what it causes, it releases slowly the 0.7 mg of the implant, but for a lesser period of time, for 3 to 6 months. Clear? So differentiating feature between the fluosinolate acetonide and this Azurdex implant is the drug basically, and the most important is this biodegradability. The Retisert, suppose after Retisert application the pressure has become very high range. So sometimes when clinically indicated, it must be surgically removed. It's not biodegradable. But if you see the Azurdex implant, it's biodegradable. Means there is a PLGA matrix which dissolves completely into the lactic acid and the glycolic acid, and ultimately it dissociates into carbon dioxide and water, which can be easily eliminated by the ocular tissue. Now we have a lot of immunosuppressive. I'll not go into the detail. If you see this cell metabolism, these are classified as antimetabolites. Also cytotoxic, where they act as a de-alkylation of the DNA. known as cytotoxic drug. Then we have the T cell inhibitor like cyclosporine and the tacrolimus, sirolimus. Now the question is when we should consider immunosuppressive. The first is non-infectious uveitis. First rule is we have to consider if this infectious etiologies are ruled out. Then just remember 3 R. First are recurrent inflammation. Second, the inflammation is resistant to steroid. Third are the patient is developing some side effects of the steroid therapy. So risk of steroid related side effects. So in such cases we can consider immunosuppressive. Now immunosuppressive sometimes can be often used as a first line therapy in uveitis. For example, vaginal granulomatosis, cyclophosphamide is the drug of choice, polyarteritis nodosa, Behçet disease, and necrotizing scleritis. These are the conditions where we use immunosuppressive as a first line therapy. Now what are the guidelines for this therapy? It's very important. First is the supervision of an experienced internist, detailed examination and side effect, and for medico-legal purpose you should take the written and the informed consent. Hepatotoxicity, various side effects are there, so this parameters has to be monitored, and dose modification, precaution to avoid pregnancy in reproductive group of people. And theoretically you should know this, that most of these immunosuppressives are very slow acting and takes 4 to 6 weeks of time to attain the desired level of the serum concentration. So corticosteroids are required initially to control the inflammation. So next is the biologicals. A lot of questions, this fourth paper in MS ophthalmology exam, one of the question will be from biologicals. It's very upcoming drug for to treat the intraocular inflammation. So what are those biologicals? So biologicals are a group of drugs which are directed mainly against the specific cytokine. So if you see the normal this inflammatory reaction, what happens? There is an inflammatory stimulus. It acts on the cytokine gene of the cytokine producing cell. Then they releases the cytokine, and the cytokine receptor they carries this signal, and the gene is activated, and they release the inflammatory mediators, and there is biological effects of the inflammation. Now we'll see what are the different kinds of biological we have. We have the cytokine inhibitor. They specifically inhibit the cytokine like infliximab, etanercept, adalimumab. Then we have cytokine receptor inhibitor like declizumab. We have drug acting on the lymphocyte like alemtuzumab or rituximab. Rituximab is known to inhibit specifically the B cell lymphocyte. We have also recombinantly produced interferon alpha. So from the name of a biological agent, you can make out what kind of drug is it. There is the clue. If the suffix mab is there, MEB is there, it indicates it's a monoclonal antibody. Okay. Now if the Z is there, means mixed human murine. This mice, murine stands for that. So it's a chimeric kind of antibody. So if this mu word is there in a biological agent, it indicates it's a human antibody. And this etanercept, sept indicates for the fusion protein which acts against the receptor domains or the cell surface markers. So the majority of these are recombinant antibody, mostly injected as a subcutaneous and the intravenous injection. Reactivation of the granulomatous infection like tuberculosis is a major and life-threatening problem which limits its use in our country. And so just to conclude, in examination take a detailed elaborate history. Thorough comprehensive examination is very important, and the documentation is also very important. You have to normally we just mark the corneal scar as a black and the iris nodule. Extent, while just documenting the KPs, you have to mention about the size, what is the distribution of the KPs, and the synechia, extension of the synechia, whether it's extending from this occlup to that occlup, and hypopyon. In a normal case of uveitis also, always remember the presence and absence of hypopyon should be documented separately. This was the Sun classification guideline, that the presence and absence should be mentioned separately. Then in fundus examination, you should, if you are examining a case of retinitis, you should mention the extent of this retinitis lesion, the choroidal tubercle, exact location, what is the size of the choroidal tubercle, pars plana exudate, it's very important. So this is about the theory exam. In practice, just remember this 6 mantras of uveitis management, recognize the clinical subtypes. Remember that history taking is most important step in uveitis management. Recall the most of the diagnoses are clinical. Rule the laboratory clinic. Don't be a slave to it. Refer to internist rheumatologist if you are in doubt. Refer to seniors and start rapid treatment, which can save the patient's eye. Thank you.